Hi everybody. Today we'll discuss about clinical examination of an ulcer. Before starting this, I would like to share few of my thoughts. While we are correcting your examination papers, we found that you have simply done cut and paste from Google. That is we are very deeply disappointed. How you just do it cut and paste? And you have not even removed some references, refer to table number 44. What is that? Where is the table number 44 in your answer sheet? Very unfortunate. And second thing, when a desmoid tumor question is given, almost everybody has written desmoid tumors in the intraperitoneum mesentery. That, okay, desmoid tumor occurs intraperitoneally, commonly as a part of FAP, familial adenomatous polyposis. When FAP is present, I am not worried about the desmoid tumors. There is something more dangerous, more grave, that I am worried. Simply desmoid tumors, will just ignore it. So what you are writing, you are not listening to what we are teaching you. I have discussed desmoid tumors. I have never mentioned intraperitoneal desmoid tumors. I just said it is a part of FAP, but not an important constituent. But everybody concentrated on the wrong side of the desmoid tumors. And second thing, you must remember all the senior faculty, we teach you because our passion for teaching, not other considerations. Okay, that you must remember. Because of our experience, we can go anywhere. We need not stay here and teach somebody who is not interested. Okay, why we are here? Because of our passion for teaching. Year after year, we are dealing with the state top rankers at AMC. That you must remember. Not that we don't have anyone coming here and teaching some uninterested students. That is not the point. So don't discourage us. We'll use our heart. If you do such things, we'll just skip away. There is no problem. This is not our bread, butter, or job. We can live happily without this job also. That you must remember. Okay, this job is nothing for us. We have done much, much better jobs than this. Okay. That you remember. I don't expect you to repeat such incidents again and again. If you do it, we'll just simply skip. We'll just leave. That's all. This is the only option for us. Not mandatory. Okay. Now we'll see examination of an ulcer. In fact, surgery started with if you take the history of surgery, it started with the wounds. How to heal or treat wounds sustained in the initial parts in the war. A wise physician skilled our wounds to heal is more than armies for the common weal. Weal means common goodness. Okay. So a physician is more than armies of a common weal. This is by Homer, Greek poet. In fact, his date of birth is not very sure. 1050 to 850 BC, they say. So ulcer is an important part of surgery, especially war wounds. That's how surgery evolved today's position. We'll first discuss few clinical features, then we'll go how to examine an ulcer. The definition of ulcer is a break in the epithelial continuity. Maybe it may be skin or mucous membrane. And here in the ulcer, the death occurs cell by cell. That's why we call it microscopic death of the tissues. Whereas if it occurs in macroscopic way, we call it gangrene or necrosis. Microscopic death or death by cell, that is known as the ulcer. And finally, it results in break in the epithelial continuity, either skin or mucous membrane. There are few important some terms in the ulcer examination. The first is floor. Floor is what you see in the ulcer is the floor, and the base is on which the ulcer rests. There is eternal confusion between the floor and base for the students. There is no confusion at all. Floor is what you see is floor, what you can't see, or on which the ulcer rests is the base. Then coming to the margin. Margin is junction between this is the epithelium. We have seen break in the epithelium. Epithelium and the ulcer is the margin. Okay. Edge is area between the floor and the margin. This is the edge. These are the few important terms: margin, edge, floor, base. Before we proceed to, we must understand this before we proceed to the clinical examination. And the clinical, again, you can classify as spreading ulcers, healing ulcers, callus. They will never heal. Pathologically, they may be specific, non-specific, or a malignant ulcer. We already see in malignant ulcers, the skin tumors, we already discussed in malignant ulcers. Again, clinical classification: spreading, healing, and callus. In spreading ulcers, edge is inflamed and edematous. They are growing, spreading. Healing ulcers, edge is sloping with healthy red granulation tissue and serous discharge. Why these tissues are called granulation tissue, already read in pathology, and how it looks like. We'll just come to that point a little later. But when you call a healing ulcer, means it must be sloping with a healthy red granulation tissue and serous discharge. Callus, it doesn't heal, unhealthy granulation tissue with indurated edge. So this is a callus ulcer. We see callus is a common word. We see some people callus. How many times you tell them, they don't listen? We call them callus people. And callus term again occurs in orthopedics also, callus formation after fracture, a common term. Coming to the specific ulcers, it could be tuberculosis, syphilis, or soft because of some specific pathology that we call it specific ulcers. Non-specific traumatic injury, arterial ulcer, venous ulcer, neurogenic ulcer, infective ulcer, all these are called non-specific. Infective ulcer common is the diabetes is common. And in arterial ulcer, each ulcer occurs specifically at some portion of the body. Malignant ulcers, squamous cell carcinoma, basal cell carcinoma, and melanoma. We have already discussed about the skin tumors, all these things we discussed. Now, sometimes a swelling starts. Already the tumor or swelling, how to examine is covered to you by HOD. Now, this started as a swelling. Then, after some time, for some reason, it ulcerated. This is called ulcerated swelling. Swelling or which ulcer impose ulcerated swelling. Another example you can see, this is a tumor and it is here, there is an ulcer. This is called fungation. This, secondary changes of a swelling. One of the is ulceration or fungation can occur in malignant tumors. This is how a tumor started and it ulcerated. History. We'll take, as usual, personal data, chief complaint, history of presenting illness, past history, family, social history, like any other case. Personal data, you take the age, occupation, nationality. Chief complaint. What is the chief complaint? What is the duration and the time? History of presenting illness. When or how did you notice the ulcer? Is it due to pain or bleeding or purulent discharge or foul smell? Maybe sometimes you will get more than one symptom. That's how the individual noticed the ulcer. And the symptoms of ulcer is that pain interfering with daily activity. Some ulcers are painful. Example, infective ulcers and arterial ulcers. Arterial ulcers produces continuous pain. That we'll discuss when we discuss about arterial system. TO, there is a continuous pain 24/7. Okay. Malignant ulcers as a rule doesn't have pain unless they involve major neural structures. Now if there is an ulcer, we'll also note is there any change in the size, shape, any discharge, pain, is it disappearing or persistent? These are all important things to be noted when pain is present. Other symptoms like fever, weight loss, appetite, brain trauma, and risk factors, comorbid, diabetes mellitus, hypertension, coronary heart disease, and vascular disease. These must be inquired. Whether the patient is a known case of DM, HDN, CHD, or so on. In the past history, where hospitalized for a long time, surgical, medical, and allergy. Like any long case, we'll take the history, detailed history. Family history will take genetic disorders, and personal history you take smoking and alcohol. Physical examination. Now, preliminary check, inspection, palpation relating to surrounding tissues. Now, in fact, before examining, you are supposed to wash hands. Even before corona also, you are supposed to wash your hands. Now, all the more necessary to wash your hands frequently. You should introduce yourself. This is the system followed in the West. In fact, when you enter a room, have a courtesy, have a decency, knock the door, ask the permission to enter into that room. That's what they do in the West. And somebody going for this FRCs or states for this diploma in the board exams, everything will be monitored. They will be monitoring everything by video cameras. How you enter the room, how you approach the patient. These are all very important. You can't just barge into your room. So identify yourself, then explain your procedure, take consent. And privacy, this is not Hyderabad exhibition grounds. Everybody has a right to be examined in privacy behind the screens. Okay. And position the patient depend upon the site, expose the ulcer area. Now coming to the inspection, we have 6 S's. Site. If you take site, we have already seen basal cell carcinoma around 90% occurs above a line joining the tragus ear lobule to the angle of the mouth. So that is a site for the basal cell carcinoma. Again, you take the lower lip. Lower lip is more common for squamous cell carcinoma. Size, length, breadth, and sometimes depth also. Shape of the ulcer or margin, is it regular or irregular? Surrounding skin, single or multiple. Finally, you examine the floor, that is surface of an ulcer. Coming to the margin, we have already seen what is the definition of margin. Now in the margin, you note down color changes. Is there necrosis or pigmentation? Coming to the edge, there are 5 edges: sloping, punched out, undermined, rolled, and everted. And remember, edge is an inspectory find. You need not to feel the sloping like in the children's park, you have these something like playing toys where children slope. You need not feel it. This is a inspector finding. Sloping edge occurs especially in healing ulcer and venous ulcer also. Punched out edge, syphilitic gum are rare, but it occurs in ischemic ulcers, arterial ulcers. Undermined edge, typical of tuberculosis. See, the much destruction of the subcutaneous tissue when compared with the skin. Rolled edge, basal cell carcinoma. Raised and averted squamous cell carcinoma. Typical, we have seen raised and averted edge in the squamous cell carcinoma. Now, sloping edge, what is happening is healing for a traumatic or venous ulcer, reddish purple in color. That means this is a healthy granulation tissue consisting of new healthy epithelium. This granulation tissue is converted into fibrous tissue, wound contracts, and it heals. That is sloping edge. Punched out here, the edges drop down at right angle to the skin surface as if it has been cut out like a punch, very sharp. Okay. Undermined edge, typically seen in tuberculosis. We have seen that ulcer destroys subcutaneous tissue more faster than it destroys the skin. So we'll have a overhanging skin that is called undermined edges. This is a rolled edge. This is seen in beaded appearance. This is seen in typically basal cell carcinoma. And averted edge, this is seen in carcinomatous ulcer. You have seen this ulcerated adenocarcinoma or squamous cell carcinoma, it can occur. Floor is the exposed surface of the ulcer. Floor, there are only two descriptions, healthy granulation tissue or unhealthy, and slough is present. Now, this is a clinical finding. Why they are called granulation tissue, you tell me later. Then, this is the definition of healthy granulation tissue. They are flat, below the level of the surrounding skin, pink in color, and do not distort. Any ulcer showing healthy granulation tissue means it is in the phase of healing. Okay. Unhealthy granulation tissue, previously they used to call it proud flesh. This is a cobblestone appearance, full of pus, discharge is present, foul smell. And there is nothing to be proud of this unhealthy granulation tissue. Our aim is to convert this into healthy granulation tissue. How to do it? Either surgical excision, curatives, or chemical. Silver nitrate is a common agent used. And sometimes wash leather slough, gametals are very rare. Nowadays you can't find that. Discharge. Now character of the discharge, the amount and the smell gives some idea. Serous discharge means it is a healing ulcer. Common. Virulent discharge, spreading and inflamed. Here infection is present. Serosanguinous means it could be tuberculosis or a malignant ulcer. Bloody discharge, first think of a malignant ulcer. Discharge with bony spicules, orthopedics, osteomyelitis. Greenish discharge commonly indicates infection with Pseudomonas. Coming to the palpation, first thing is you see the temperature of the surrounding tissue, then tenderness. Third is induration. What is induration? Hardness or thickening. Whenever you see induration, think of carcinoma. One. Second thing is think of a chronic ulcer. Now, what is an acute ulcer? What is a chronic ulcer? Unfortunately, the books you read, this Makanlal Shah, Rajgopal Shenoy, and all these books, they are not given a proper definition. Internationally, it is accepted as any ulcer lasting more than 6 weeks is chronic ulcer. Less than that, acute ulcer. This is international definition. Most of the books they gave 2 weeks. I don't know how they Indianized it. Make in India, maybe they change the definition, which are not accepted universally. And you are Rajgopal Shennai, and there is another book called Surgery Perils, Dayananda Babu. In fact, most of them are my friends. We were together as panelists in number of CMEs. They're my friends. Still, I don't agree whatever they written in the book. Okay. So, hardness occurs in carcinoma. One, chronic ulcer. The definition of chronic ulcer is any ulcer lasting more than 6 weeks. Below 6 weeks, less than 6 weeks, it is an acute ulcer. This is the international definition. Somebody said 2 or 3 weeks, I am not worried about that. So, brawny induration occurs in abscess. And margins of the ulcer mobilize. You hold the ulcer and try to move it. If it is small, it moves. If it is fixed to the underlying structures, it may not move. Now, edge of the ulcer we have seen. This edge of the ulcer is the inspector finding. Base we have seen. Disorder and bleeding. This is a very important point on palpation. If it bleeds on touch means think of malignancy first. Okay. In other subjects also they will tell you bleeding on touch. This is not a healthy sign, not a physiological. It is pathological. Mostly it could be malignancy. Now move the ulcer. Okay. Then malignant ulcers will be fixed to any of the deeper structures by infiltration. Malignancy fixes. You see the surrounding tissue, venous ulcers surrounded by hard and black skin, pigmentation will occur. And some ulcers get adherent to deep structures like tendons, periosteum, and bones. You have to examine the local blood supply, examine the arteries, veins, the bone below the ulcer. Veins important in varicose ulcer. Arteries, pulsations important in the case of arterial ulcer. Now, what is the common site for arterial ulcers? They occur at the distalmost parts or pressure areas like the tips of the toes, medial malleolus, all these things where the blood supply is not very good, it occurs because of the decreased blood supply. And there, as a rule, they are painful. Arterial ulcers, as a rule, are painful. You examine the local vascularity and also you examine the regional lymph. When there is an ulcer over the last toe or fifth toe of the foot, say right foot, which group of lymph nodes you examine? Do you examine oblate lymph nodes, inguinal, or both? It's all anatomical knowledge. We will not discuss that. Okay. Then there are some ulcers with no lymph nodal involvement. One example we already discussed is, we have discussed two examples. One is basal cell carcinoma, other you type it. Okay. And you examine the nearby joints also, both active and passive movements. Then general examination of the other systems. Once you finish this, you have to put a clinical diagnosis. What could be that diagnosis? Is it a malignant ulcer, traumatic ulcer, or a venous ulcer? Anything you have to offer a provisional diagnosis. Basing on your diagnosis, we'll go for some investigations to confirm your diagnosis. And one of the investigations is biopsy. Where do you take biopsy from an ulcer? That is very important question. The general rule is wedge-shaped biopsy from the edge of the ulcer. That is the standard answer. Shape is wedge-shaped from edge. You may ask why from edge, why not from the center? Edge is the growing part of an ulcer. Most of the activity is occurring here. If you go into the center of the ulcer, there may be necrotic tissue and you don't get, or pathologists cannot give any report. So always the best site for biopsy from an ulcer is wedge-shaped biopsy from the edge of an ulcer. This is a standard answer. Okay. Once you do all these things, you put a diagnosis, provisional diagnosis, investigations, then treatment. And most of the times, this will be kept as a ulcer will be kept as a short case for you. There is a limited time. You have to take the history of relevant points, not more than 3 or 4, then go for examination. Very rarely, they may give an ulcer, big ulcer with massive lymph nodes as a long case where you have sufficient time. But most often it is kept as a short case and you have to finish the examination within the stipulated time. Now you can ask for any questions. ఎలా చేయాలి క్వశ్చన్స్ కి
తెలుసు సార్
అది తెలిసిందా అది పెట్టేయండి Okay, the question is how to differentiate arterial and venous ulcer clinically. The first and foremost is venous ulcer. Venous ulcer typically occurs near the medial malleolus, whereas arterial ulcers occurs, we have told you, in the distalmost part, that is over the tips of the toes. One, they may be multiple, two, and they are, as a rule, they are very painful. Or they may occur over the pressure areas. In an arterial disease, the typical Western book says the pressure of a woolen blanket over the feet can produce an ulcer. See how much weight will be the woolen blanket in the Western countries. They're all cold countries, temperate, okay. Even that pressure can produce ulcer. And again, you see the arterial system. You examine the dorsal asperities, all the arteries, you will compare that there is a diminished arterial pulsation. Second thing, in a typical arterial ulcer, in advanced stage, the patient will have 24/7 pain 24/7. No lunch interval, no tea interval, 24/7. And they keep on hanging their foot because of the gravity, blood flow will be more and they will get some relief, not full relief, some relief. Or they will be crouching their feet because pain. And they request you, beg you literally to do some amputation because pain is so severe and it is continuous. Venous ulcer, unless infected, it need not have pain. But arterial ulcer, because of the infection and insufficiency of the blood flow, there will be continuous pain. That's how you differentiate clinically. That's why I said after the examination of the ulcer, you have to look for the arterial system, you examine, venous system, you examine local nervous system also, any sensory defect. Basing on the location of the ulcer. If it is in the sole, definitely you should examine the sensory system because it doesn't have any Commonest cause is any neurological disorder. And in our region, you think of a diabetes, uncontrolled diabetes, neuropathy, vasculopathy, they do not feel any pain, and there is a big ulcer perforation. That's how you clinically differentiate between arterial and venous ulcer. Again, venous ulcer, you can have a varicose, you can see varicose veins, pigmentation, hardness. That's all a typical of venous ulcer clinically. Any other questions? Invariably, one ulcer case will be kept for you in the clinics. Invariably, for everybody. So you must know how to examine within the stipulated time, how to elicit a relevant history, and how to quickly finish the examination before the time is over. Everybody will get an ulcer case, 100%. Provided they're present at that time. Generally, they will be available. So, not a problem. Any other questions? Okay, if there are no questions, we'll close down. ఇది ఒక సేపు చూసి. Okay, see.